Can you see the screen?
Yes, sir.
Fine. So we will go for the new topic, that is ulcerative colitis, Crohn disease. They are actually, we consider under inflammatory bowel syndrome, uh, or IBDs, actually inflammatory bowel diseases, and in that there are 3-4 diseases which are there. We'll have a quick glance or a quick comparison between various these. Many people get confused with irritable bowel syndrome and IBD. Actually, IBD is inflammatory bowel diseases where the inflammation is there in bowel. Bowel means GIT, and that disease, the diseases in which there is inflammation to bowel, we call it as an inflammatory bowel disease. Now in that there are 4 major diseases are there. These are ulcerative colitis, Crohn's disease, irritable bowel syndrome, and celiac disease, or celiac disease we can call. So these 4 are there. We'll have this comparison that how we can distinguish in these. So this will make it easy. We'll go for then other ways and how we treat it. So let us have age-wise ulcerative colitis. Any person can have. Crohn disease, any person are there, but IBS is more in young, and particularly in adults. The celiac diseases are more comparatively in 3rd or 4th decade. Gender, male and female are equal, but in IBS the females are having preponderance, and even celiac diseases are females are having almost double chances than male. It is various countries in western countries are comparatively more in almost all, and more, while these celiac diseases are more in northern Europe, and prevalence in Europe is approximately 1%. Ethnic group any can have, but this the Crohn's disease, they are more with Jews, and not details are there. Whether some genetic factor are responsible, yes. So particularly for this ulcerative colitis, the genes related to HLA-DR103, they are associated with the severe disease. Here it is CARD15 and not 2. These mutations are responsible. While in case of inflammatory bowel syndrome, irritable bowel syndrome, it is not clear. And the celiac disease, genetically susceptible individuals, they are intolerant to wheat gluten and similar proteins in rye, barley, and oats. They also having HLA link, autoimmune disorders, and in certain diseases. What are risk factors? In most of cases, smokers, ex-smokers, those who are having appendix removed, that is appendectomy, if it is there, then it protects. Okay, it is more common in the non and ex-smokers. Then the Crohn's disease is more common in the smokers. This one, the irritable bowel syndrome is more in the person with having history of psychological stress, and it is not mentioned as a risk factor, but celiac disease is associated with HLA-linked autoimmune disorders, and certain diseases like insulin dependent diabetes mellitus, thyroid, primary biliary cirrhosis, then other inflammatory bowel diseases apart from celiac diseases like Crohn's disease or this, then Sjögren's syndrome, deficiency of immunoglobulin A, pernicious anemia, sarcoidosis, myasthenia gravis. So many things are there which can cause celiac diseases. Now how we go for diagnosis? Clinical confirmation by biopsy. Although sign symptoms are there, we'll see sign symptoms later. Here also the next, that is both, that is Crohn's disease, and you can see both are almost matching at many places, Crohn's disease and ulcerative colitis. The clinical diagnosis is supported by symptoms more than 6 months, but worsened by stress. The FBC and ESR, they are normal. The endoscopic, in celiac disease, endoscopic small bowel biopsy is a gold standard. Now this word you may encounter or might have encountered earlier. Whenever treatment or whenever some diagnostic tool is there, and that is the best tool, So that is called as a gold standard. Gold standard means there is nothing better than it. So whether it is a treatment option or whether it is a diagnosis option, we call it as a gold standard. That means this is the best treatment, or this is the best option possible. Endoscopic and small bowel biopsy is with gold standard. IgA endomysial antibodies by immunofluorescence, hematology, having micro and macrocyte anemia, and biochemistry can be checked, that is calcium, magnesium, protein, albumin, vitamin D, etc. So these all will be helping it. Now this is a very important one, that is which area is basically affected by this. This can be one of the important diagnostic feature. This one, the first one, that is ulcerative colitis, is only colon. It begins as anorectal margin with variable proximal extension. Anorectal means the lowest portion or the most away. And proctitis, then that is inflammation of rectum. Proctosigmoiditis, that is rectum and sigmoid colon are affected. And pancolitis, that is pan means complete, whole colon is affected. So colon is more affected. While Crohn's disease, any part of GI tract can be affected. But it is perianal, that is surrounding anus, common patchy distribution, skip lesions are there, sites involved in order of frequency, terminal ileum and right side of colon, colon alone can be affected, or ileum alone can be there, ileum and jejunum can be affected. Then we can check with the colon whether there is a inflammatory bowel disease, and particularly the celiac disease is because of the small bowel. Apart from extraintestinal manifestation, whether they are, so yes, they are common. Apart from intestine, that is large or small intestine, apart from that some other effects are also there. We shall see them in both ulcerative colitis as well as Crohn's disease. In case of this inflammatory bowel syndrome, it is associated with other symptoms like dysmenorrhea, non-ulcer dyspepsia, fibromyalgia, etc. And here also these are common when it is the case of celiac disease. Presentations, what are the sign symptoms? On what basis you can start diagnosis, or what we can say chief complaints? So here the ulcerative colitis, bloody diarrhea, that is then proctitis, that is rectal bleeding, mucus discharge, then tenesmus, prostosigmoiditis, that is we have seen just now, that is rectum and sigmoidal colon inflammation, bloody diarrhea with mucus, some develop fever, that is extra colon symptom we have seen, or extra intestinal symptom, lethargy, abdominal discomfort. Then it can cause extensive pancolitis. Pan means complete, whole colon is inflamed, therefore bloody diarrhea with passage of mucus. In severe cases there will be anorexia, malaise. Malaise means feeling discomfort or feeling uneasiness, weight loss, abdominal pain, patient is toxic with fever, tachycardia, and signs of peritoneal that is peritoneum is also getting inflamed with this simultaneously. Here also there is a pain, diarrhea, weight loss, these are all common. Then ileal Crohn's disease, that is ileum is more affected, and therefore there may be subacute or even intestinal obstruction. Diarrhea, watery but no blood or mucus. Crohn's colitis, which is identical to ulcerative colitis, but rectum is spare and presence of perianal disease is there. Many are having the symptoms of both small bowel and colonic disease. In some there can be isolated perianal. Perianal means surrounding the anus disease. Many presents with the symptoms of both small bowel and colonic disease. In few the isolated perianal disease will be there. Vomiting from jejunal structures and severe oral ulceration will be there. Then in this irritable bowel syndrome, that is recurrent colicky abdominal pain will be there. Cramping is there, relieved by defecation, abdominal distension, episodes of diarrhea. but they can have more of a constipation pattern. Patients will no weight loss, depends on age and of onset, infancy, diarrhea, malabsorption and failure to thrive. Symptoms starts after weaning on the cereals. That is, we have seen that gluten may be responsible. So, gluten free diet can be given to these people in this celiac disease. Older children, non-specific features like delayed growth, malnutrition, mild abdominal distension, growth and puberty delay, because of basically all these are consequences of malnutrition. Adults, highly variable sign symptoms are there depending on the severity and extent of small bowel involvement. More some fluoride malabsorption, others are having non-specific symptoms like tiredness, weight loss, folate or iron deficiency anemia, oral ulceration, dyspepsia and bloating, mild undernutrition and increased risk of various osteoporosis and other such diseases. Now again diagnostic one, when we go for histology or when biopsical sample, biopsy means the portion is removed, then this biopsy is there, and from biopsy what we get is inflammation is limited to mucosa. There is a crypt distortion, then cryptitis, crypt abscesses, loss of goblet cells, submucosal or transmucosal inflammation is common. Deep fissuring ulcers are there in case of this Crohn's disease. Fistulas, patchy changes and granulomas, these are there. These are actually the symptoms at as it extend as it goes towards moderate and severe disease. Here histology, it is a normal in case of inflammatory irritable bowel syndrome, and in case of celiac disease, subtotal villous atrophy, that is villi are there, they are atrophied. Sometimes villus appears normal, but there may be excess number of intraepithelial lymphocytes which are playing a role into it. So these are various what we can say differentiating or comparison between these four, that how these diseases are. Now we will go for still some more details, that is basically both are having diarrhea, or rather almost all are having diarrhea. Diarrhea only differ, either mucus is present, mucus is not present, it is watery stool or thick mucus stool with blood or without blood, and on that basis, and how much area is involved, on that basis they are there. Basically ulcerative colitis and Crohn's disease are the major one in this. Here ulcerative colitis is limited to the colon, while we have seen this, while Crohn's disease can occur anywhere between mouth and anus, but it is more in ileal area. In Crohn's disease there are healthy parts of intestine, they are mixed with in between inflamed area, while ulcerative colitis, it is continuous inflammation of the colon. Ulcerative colitis only affects the innermost lining of the colon, while the Crohn's disease can occur in all the layers of the bowel walls. So these are basic important differences which are having. Now let us go for more details about it, and how these inflammatory bowel diseases are there, how they are treated. We'll go one by one. Just a minute, let me change the presentation. So we have seen so far, let us go for that. Inflammatory bowel diseases, these are idiopathic disease, these are occurs by dysregulation of immune system response to various intestinal microflora which is there. We know there is a microflora, various microorganisms are present, and because of these the reaction, normally they are not having any kind of reactions to the host, but here they may show the immune response, and therefore they will affect this intestine. There are two major types we have seen, ulcerative and Crohn's, and two more are there as we have seen, that is this irritable bowel syndrome and the celiac disease. So basically these are four, but most important are whenever we go for that, most important are considered as ulcerative colitis and Crohn's disease. So in what is ulcerative disease is inflammation which is associated with ulceration, edema, bleeding, and the fluid and electrolyte loss, while in Crohn's disease it is affecting any segment of GIT tract from mouth. We have seen this is a differentiating factor, and it involves skip lesion, and it is transmural, that is across the layer it is there. So these are various inflammatory mediators has been identified in this, and there are evidences are there that they play important role in the pathological and clinical characteristics. Example which are mediating it, these are various cytokines. These are released by the macrophages in response to various antigenic stimuli. They bind to different receptors and produce autocrine, paracrine, and endocrine effects. Example of these are cytokines. They are differentiating like lymphocytes into different type of T cells, like helper T cell, T type 1 or thymal T1 cells. They are associated principally with the Crohn's disease, where the T1 type of cell or Th1 cells are more. Th2 type of cells are more associated principal with the ulcerative colitis. I hope last year pharmacology, if you have studied this immunosuppressant agent, at that time you might have seen various agents which are how they are playing, how the immune response are playing role, and how various immunosuppressants they are targeting these various areas. Now this immune response disturbs the intestinal mucosa, and it leads to chronic inflammatory process. It features as a genetic predisposition. We have seen HLA type and other type of varieties that there is a mutations or changes are there, and the patient with these conditions are more prone to the development of malignancy. So this is another problem which are associated, that these patients with inflammatory bowel disease, they are more prone for colon related cancers, that is colon cancers are more in these patients. So let us see the figure what happens. So there is a healthy microenvironment which is there, and what happens into this. So there is a normal conditions, there is a mucous layer is there, and cells are there. Now when there are antigenic reactions are there, because of that this prostaglandin E2 is released, and there is a immune tolerance is there because of the mucosal homeostasis, that mucosa is produced, and therefore nothing can happen. But if we compare it with this condition, what will happen? Here this protection is not there, and because of that the matrix destruction will be there. That is this MMP is a matrix metalloprotein enzymes are there, which are particularly released by neutrophils and various phagocytotic enzymes. So these will be releasing here bacterial persistent with the macrophages, and the inflammatory areas are there. Various interleukins are there, like interleukin 1-2, interleukin 2-3, interleukin 1 beta, TNF alpha. These all are inflammatory cytokines are there. They will be playing role, and they will be causing inflammation. So these are the consequences, and this inflammatory response to the mucosal ulceration or the innermost layer, that will have inflammation for that. And simultaneously this may also result into clonal expansion. Apoptosis will decrease, lack of response to various things, including like interleukin 10, then tissue growth factor beta, they will be changing. So these are various symptoms are there. Again, abdominal pain is comparatively more in Crohn's disease. Anemia is more in ulcerative colitis. Arthralgia is more in ulcerative colitis. Bleeding is more in ulcerative colitis. Diarrhea is more in ulcerative colitis. While the Crohn's disease will have very, very high percentage of figure, that is fever. The fistula, that is particularly problems in the anus will be there, sort of wound will be there in the anus, that is called as a fistula, and 16% of the person will have a fistula because of the Crohn's disease. Then iridocytitis, uveitis will be almost same in both, but weight loss it be very high in Crohn's disease comparative to ulcerative colitis. So these are the again differentiating features between ulcerative colitis and Crohn's disease. Epidemiology, slowly year by year, maybe diagnostic tools we have got increased, more people are coming, so it shows there is an increase in people who are coming for that. I will not go for this clinical and economical burdens, will directly go for treatment about it. So how we are going to do it, how we are going to make the diagnosis. The optimal IBD management has historically having underdiagnosis and misdiagnosis. I told you, because we are nowadays many diagnostic tools are present, and therefore the figures actually now whatever figures you will get will be correct. The previous figure we should not pay much attention to. The UK study show that 10% of the patient with IBD were misdiagnosis with the irritable bowel syndrome. Okay, that is IBS. Then there are 4,000 patients with IBD in the US reveal that the accurate IBD diagnosis may be even difficult to attain the what previously thought, because there are many factors, as I told you, they are involved, and this is very latest 2017, just 3 years or 4 years back. Still it is found that it is not easy to diagnose, and it takes it makes a big difficulty to make it. 62% respond needs and there more than 5 office visit before receiving an accurate diagnosis. So minimum 5 times they have to reach, and then only they could get it diagnosed. How we are going to diagnose it? So the diagnostic things are go for the traditional upper endoscopy and colonoscopy with biopsy. It represents the standard for IBD diagnosis. Then capsule endoscopy, that is again the probe is put into capsule is taken, and then from that the what we can say wireless probe will be giving the idea about it. So this is what endoscopy is there. Then it will evaluate the segments of intestine and areas outside the bowel that cannot be reached by the traditional endoscopy. Then various X-ray, ultrasound, CT, magnetic resonance imaging, these are the various techniques can be used. In addition to these are the histology, we have seen biopsy. Then clinical symptoms, we have seen diarrhea, presence of blood, absence of blood, type of stool, we have seen this. Laboratory findings and microbiology findings, whether there is any infection to that area. So all these come together to actually give some idea about IBD, what kind of IBD it is, whether it is inflammatory, whether it is ulcerative colitis, whether it is the other type, that is Crohn's disease, and whether it is the irritable bowel syndrome or celiac disease. So these are various tests are there. Screening test for intestinal inflammation, which includes the diarrhea and pain whenever it is there. It can be detected through number of laboratory analysis, including blood cells and proteins in the blood. Blood biomarkers like C-reactive protein, ESR, they are there. ESR is, that is erythrocyte sedimentation rate. While stool biomarkers, they include calprotectin and lactoferrin. When it is present, then accordingly we can understand. Specialized serological tests nowadays are available for diagnosis of Crohn's disease, which can distinguish Crohn's disease from ulcerative colitis or vice versa. Example are PANCA, ASCA. These are all genetic markers are there, which shows various indications about it, and it may be included in the serological test, and they are present in the approximately 80% with the inflammatory bowel diseases. So screening test for intestinal inflammation should be included in the workup for all patients presenting with diarrhea and pain. Go for laboratory analysis and then decide what kind of actually problem is. So these are the tests, these markers are there, that is anti-neutrophil cytoplasmic antibodies. then anti-Saccharomyces cerevisiae antibodies to outer membrane porine, flagellin related antigens, Pseudomonas fluorescens associated type of these. Then these are newly identified, and one, that is flagellin A4 FLA2 and FLA-X antibodies. Then anti-laminar this biocide carbohydrate, this is anti-Clygan antibody. Then these are then anti keto biocide carbohydrate antibodies, that is IgS, anti-synthetic monocyte antibodies, pancreatic antibodies. So these are various antibodies are there. And then how we can make it, how it gives you differential diagnosis. That is, they are 2 to 28% in CD, while 20 to 85% in ulcerative colitis. Now, only thing is confusion will be there when it is around 20 to 30%, because in both cases it is common. However, these are quite clear one. That is ASCA, that is anti-Saccharomyces, 29 to 60% it will be there in Crohn's disease, while only 5 to 15%, it will go beyond 15% in ulcerative colitis. Same is the case, this the outer membrane porine, that is 24 to 50% in the Crohn's disease, 5 to 11% in ulcerative colitis. Then next is 50% in CD, 5% to 11% in ulcerative colitis. Here to 20 to 50% in Crohn's disease, 2 to 10% in ulcerative colitis. Then above 57% will be there in CD, and nothing is there in Crohn's disease. Nothing is there in ulcerative colitis. Similarly, one by one you will see that is 17 to 28% Crohn's disease and only 4 to 7% ulcerative colitis. 20 to 25% in Crohn's disease, 5 to 15% in ulcerative colitis, around 20% in Crohn's disease, 18% in ulcerative disease colitis, 30 to 40% in Crohn's disease, and 2 to 6% in ulcerative colitis. So this is how diagnosis is there. These are various tests. Then fecal calprotectin, that is FC, and fecal lactoferrin, they are useful screening for the IBD. Various tests shows that the pull sensitivity and pull shows that is FC, that is fecal calprotectin is around 0.93 and 96 in children, teenagers it is there. So it will result in 7% and 30% reduction in the number of adults, children, teenagers requiring endoscopy, because only in fecal matter we can go for the diagnosis. It is cost effective due to avoidance of unnecessarily endoscopy. Endoscopy needs comparatively it's a costly one. So this is the technique, and how it is economical. This is sort of issue of pharmacoeconomics, that how we can get it done with lesser amount or less money is there. Now what should be the treatment? Okay, how the evidence based treatment should be given. So this is the graph shows, that is the lowest one is in that is 5 acetyl salicylic acid analogues and antibiotics are given. Then the next better types of treatment is various steroids like prednisolone, budesonide, etc. Then still next is immunosuppressants like tacrolimus, azathioprine, etc. Now these are the new molecules which have come into this. These are various monoclonal antibodies like infliximab, adalimumab, certolizumab, golimumab, vedolizumab, then natalizumab, and ustekinumab. These are various monoclonal antibodies which are nowadays, these are comparatively very newer one. And lastly surgery, if still it is not there, it can be there. And apart from that, there is one more newer biological is there, that is tofacitinib. If you remember last year we have had one topic of pharmacology when few people have asked me a question about newer anti-cancer drugs, and there we had a class about MAB, NIBs, isn't it? So NIBs are, they are acting on various various kinds of tyrosine kinases. They are the modulators of tyrosine kinases, while MAB are monoclonal antibodies against various either hormones or neurotransmitters, or antibodies against antibodies. Depending on that, these are various specific drugs, or they are targeting as antibodies. Now, what are the treatments? What the treatments are there? So we have got two important things. We have to go for guideline-based care and personalized medicines for people depending on their situations. So what are the things, or what are the important things we have to consider? What is our main target is change the course of disease, go for the remissions, go for mucosal healings, steroid free remission as far as possible. We are not going to use steroids. Clinical remissions, total clear and improve in the symptoms. These are what our activities. Simultaneously we can have various assessments, that is disease severity, what it is, whether there are comorbidities, and then what are the first treatment choice, second treatment choice, third treatment choice, and what will be the alternative treatment choices. So what are the treatment? Let us see one by one about treatments, which treatment we shall be going. So various pathways are there, that is clinical pathway and evidence-based treatment guidelines. So on that basis, this evidence-based treatment guidelines gives instruction, while clinical pathways, they suggest that is you go for this prescription or you go for these medications. So these are various conditions. Let us see. Make diagnosis. What will be our algorithms for ulcerative colitis? Let us see. Make diagnosis, check the inflammatory status, assess the comorbidity and disease therapy related complications, stratify according to the colectomy risk. If it is a low risk patient, then go for inductive and maintenance therapy. If it is high risk patient, identify and patient requiring hospitalization. If require inpatient, then go for the therapy for this high risk patient, because you are admitting patient considering difficulties. Then if it is outpatient, then accordingly give the treatment, and accordingly check the outcomes. What should be the chronic Crohn disease? This is just overview. Assess again inflammatory status, assess the comorbidities and disease and therapy related complications, what are they, assess current and prior disease burden, identify the low risk patient, whether the patient is low risk or high risk. Then if it is low risk, then perform initial treatment, that is whatsoever for the low risk patient. And if it is high risk, then either again admit into hospital as an inpatient and go for patient in the remission mode, that is moderate to high risk patient, and see that there. Okay, so whether the patient goes in remission or is not going to remission. If it is not going to remission, then go for the alternative whatsoever treatments are there if the medications are not able to do the job. So let us see various drugs, and accordingly what treatments are there, what should be the treatments which is there. Now the thing is, problem here it is basically some of the pages are there on the pair approaches like that. Basically the newer treatments are very good. Which are newer treatments? These are the antibodies, monoclonal antibodies, or this tyrosine kinase modulators. They are good. Only problem is they are very costly because they are under patent and the cost is exorbitant. So one of the new drug recently came, I don't know whether you people have seen it on WhatsApp or not, but in Indian currency that one vial cost around 18 crores. So this is not IBD drug, actually it is for other purpose, but these are all biologicals. So all these biologicals they are costing tremendously, and therefore since they are costing so much, the thing is whether those who are covered with the insurance with appropriate amount available, they can go for that, otherwise it cannot be possible for that. So this will be the difficulties will be there. So let us go for various treatments for that. So these are various treatments which are suggested. I'll just make it. So go for the analysis. We have seen that what kind of conditions are there. So in case of ulcerative colitis, what we are going to use? So there are various recommendations. That is, go for the drugs which are of new kind. I told you cost is an important factor. These are the new drugs. All are what? Monoclonal antibodies like infliximab, adalimumab, golimumab, vedolizumab, then tolfasitinib or ustekinumab. They are the better one. They are found to be, and even the quality of evidence is good. The adult outpatient with moderate to severe this ulcerative colitis, who have NAVE means who have never used these biological agents. This American Gastrointestinal Association suggests that using this type of agents only, that is infliximab or vedolizumab, and they should not use adalimumab or for induction or remission, because it is still newer one. These two are quite older one. The patients, particularly those with less severe disease, who place higher value on the convenience of cell administration, subcutaneous injection, and lower value on the relative efficacy of medication, may reasonably choose adalimumab as an alternative, because it can be self administered. The outpatient with moderate to severe ulcerative colitis and who are new to biological agents, the tofasitinib only be used in the setting of the clinical or registry study, that is only clinical studies. If you know, nowadays unfortunately, if you are reading WhatsApp messages or all the things, you will find that people are going very tense and having a very worse situation with remdesivir injection nowadays. Even newspaper you will find. But at the same time, actually it is also under a trial drug. It is a study drug as such. Okay, because still results are not out. So similarly here it is suggested that these drugs, this tofasitinib, should be used only in setting of clinical study or registry study, where already it is studied as a clinical study, then it is given, because it is still under study and the data is not there. We cannot have a very clear-cut guidelines for that. The adult outpatient with moderate to severe ulcerative colitis who have previously been exposed to infliximab, particularly those which are primary non-responsive, the use of ustekinumab or tofacitinib rather than vedolizumab or adalimumab for induction of remission, these are too good. In the adult outpatient, when active moderate to severe ulcerative colitis, AGA suggests using thiopurine monotherapy for induction or remission. So don't go for the thiopurine drugs. Actually these were one of the important drugs nowadays. Since these drugs, newer drugs are there, they are comparatively safer and more efficacy is there. They have taken now more importance. The adult outpatient with moderate to severe ulcerative colitis in remission, using thiopurine monotherapy rather than no treatment is better. Okay. So instead of no treatment, thiopurine is better, but instead of thiopurine, newer drugs are better. Okay, in active to moderate, the thiopurine has no big role, but in milder cases it is useful. The outpatient with moderate to severe ulcerative colitis in remission using thiopurine monotherapy, then no treatment is better. In adult patient moderate to severe, use of methotrexate monotherapy. Again, moderate to severe, we are going the immunosuppression. Methotrexate is one of the immunosuppression. Then in the patients with active to moderate severe ulcerative colitis, we use the biological monotherapy like TNF alpha antagonist, then vedolizumab or ustekinumab or tofacitinib is better rather than thiopurine monotherapy, because which is active and moderate to severe one. So in that, thiopurine is not that useful. The adult outpatient with moderate to severe ulcerative colitis, the recommendation is in favor or against of the biological monotherapy or tofacitinib rather than thiopurine again for this. The TNF alpha antagonist vedolizumab or ustekinumab along with thiopurines can be given for the moderate to severe one rather than monotherapy. That is, again you can add. So you can combine thiopurine with this some of these monoclonal antibodies or tyrosine kinase inhibitor. The patient who are less severe disease, who place higher value for the safety of biological monotherapy and lower value on the efficacy of combination therapy, may reasonably choose biological monotherapy. The adult outpatients with moderate to severe ulcerative colitis, combine TNF alpha antagonists and vedolizumab or ustekinumab with thiopurines or methotrexate rather than thiopurine monotherapy. So again, as it is, if it is not clear, it is not there is a no good remission with earlier one, then here we are adding on the treatment, we are adding the number of combinations. Then the early use of biological agents with or without immunomodulators therapy rather than gradual setup after failure of 5-aminosalicylates molecule. Okay, so 5-aminosalicylic acid molecules, salicylic acid derivatives are there, they can be used. Okay, then patients, particularly those with less severe disease, who place higher value for the safety of 5-SA therapy and lower value on the efficacy of biological, or then they can go for gradual step, that is, first go for this the older drugs because it is economical also, and then go for the newer one. The patient with moderate to severe ulcerative colitis have achieved remission with biological agents like immunomodulators or tofacitinib, then continue for 5-aminosalicylic acid derivatives for induction and maintenance of the remission. The hospitalized with this, the patient which are hospitalized, it suggests the intravenous methylprednisolone dose equivalent to 40 to 60 milligram per day rather than higher doses of intravenous corticosteroid. In hospitalized adult patients with acute severe ulcerative colitis without any infection, so there is no need of antibiotics if there is no infection, so antibiotics should not be given. The person refractory to intravenous corticosteroids, then use infliximab or cyclosporine to this. Again, infliximab is an antibody against interleukins and cyclosporine is one of the immunosuppressant agent. The hospitalized adult patient with acute to severe ulcerative colitis being treated with infliximab, there is no recommendation on routine use of intensive versus standard infliximab dosing. So these are the various conditions, these are various trials, and these are showing various impacts, that how the drugs, how it can be effective, how we this ulcerative colitis can be treated for that, and what are the various guidelines. So these guidelines give you idea about use of the drugs, that is particularly in mild to moderate one, you can have 5-aminosalicylic acid derivatives, that is mesalazine and such kind of aminosalicylates. Then as you go ahead, then go for the steroids, and you can give them parenterally, and if still it goes severe or beyond severe, then go for, if you remember the pyramid, then go for the biological one. This is what is nowadays being going on. As I told you, biologicals are very costly, and therefore this economic considerations, they have to be done. they have to be checked, and accordingly one can proceed. So this is how one can go for, one can make the things and go for the treatment. We'll go for the other treatment, that is Crohn's disease, in our next class. It is almost same. Again, there too we are using almost similar treatment. Very few changes are there. So this remaining two we shall see in next class. Then we'll finish this topic about inflammatory bowel diseases, where we'll have emphasis on ulcerative colitis, Crohn's disease, and some attention over that is irritable bowel syndrome and celiac diseases. Okay, the major focus, however, will remain on these two, that is ulcerative colitis and Crohn's disease. So these are the important conditions, important problems which are there in what we say inflammatory bowel diseases. Today I could see very less attendance. I don't know why. Only 11 students are present. Only 10 students are present.
Yes, sir. So some are having network issues, and the backlog students, they are having their papers today.
Okay, okay.
Yes, sir. So
Okay.
that's why.
Anyway, so fine then, because this was important topic. Many do not get idea, or they do not get understanding with this. Actually, we already told, they could have requested that we could have postponed it otherwise, if they would have been interested. But anyway, we have finished it. We'll go for the we'll finish the remaining. In the meanwhile, those are interested, go for various liver function tests which you might have studied in pathophysiology. You can take it as a assignment, how various liver function tests are done, what are the various sign symptom to understand problems in the liver. And I'm very sure, I think you might have studied it in pathophysiology, various liver diseases including jaundice, what are their pathophysiology. If possible, just have assignment on this, that is, what are various liver diseases, what are their etiopathological factors, how it occurs, so that we'll just go for the treatment part in more details. Only whatsoever things, strings which are not there, that we shall add up into it. And if you have any difficulty so far, you can ask about it. So take care and be safe. Please be very watchful, because this is very dangerous situation in Maharashtra nowadays. It is sort of, bomb to explode. We are in conditions, and at many places drugs are not available, beds are not available, oxygen is not available, and unfortunately people are they are not taking precautions. They are having their own heroics. So being a student of the healthcare system, you try to see that how you can guide them, and you can avoid this. You can help the government to control this, because really pathetic situation actually nowadays it is there. Last 2 days so many people were in touch with me, that many are hospitalized, and the oxygen they cannot get, or what we can say, bed they cannot get, or remdesivir they cannot get. And most of them, still many are not aware, still many are they are worrying to get it tested. So I suggest everybody to get it tested. Even small symptoms, observe the oxygen content carefully. Very important to observe the oxygen content, and go for the means you can guide them accordingly. So see that you can help people, you get good knowledge. If you have any difficulty, can ask. Okay, and you just be careful about yourself, your family members, relatives. Take care.